The very first patient that I ever had the opportunity to start buprenorphine for during acute hospitalization, he was a 44-year-old gentleman who was admitted to our hospital with infective endocarditis. It was actually his third readmission for this condition, but had self-discharged because, as we would learn later, he would say that we did not adequately treat his withdrawal, we did not treat his pain, that we were really sort of hyper-focused on his cardiac condition without thinking about the rest of him as a person. A week into the hospitalization, his nurse found him to be injecting heroin through his IV. And there was sort of a heated dispute that followed between this patient and the nursing staff and the pharmacy staff and the rest of the clinical staff about, this being an inappropriate activity and how sort of upset we were. And the patient kept saying, nobody cares about me. All you care about is my heart infection, and nobody is helping to address my withdrawals. And so I went to go see him, and I sat at his bedside. He was very agitated. He was very upset. And I sort of explained to him that, one, I was so sorry that he felt that we were not treating him as a whole person, that we were learning and that we were really trying to change our practice, that we were striving to provide better patient-centered care for people with history of intravenous drug use. And that it was not that he was a bad person. It was not that he was undeserving of care. It was that the system really wasn't designed to help care for him in a way that could help him achieve recovery, however he defined that. And essentially, he agreed to start buprenorphine. And of course, we thought it was going to be this big complicated thing because we had to do this big training and all of that. Of course, it was nothing like that, right? It was so straightforward, evidence-based, safe, and very applicable to providing patient-centered care for this patient. And I came back the next morning, and I remember just hearing singing and laughter coming from the end of the hallway. And he was sitting on the sofa that's in the patient room, looking outside of this picture window, looking down onto the state capital of Texas. And he's playing the air guitar and he's singing Led Zeppelin, and he has a big smile on his face. And he is just so incredibly appreciative that we worked with him, that we understood why he injected heroin through his IV, and appreciated that part of that reason was that we as a clinical team were not addressing him as a whole person. And so he felt heard, and he felt better. We started the medication, buprenorphine, and his withdrawals had dissipated overnight. He was feeling well clinically, but also feeling well as a human. And for the remainder of that hospitalization, he did not self-discharge. Back in 2017, we were on a journey to better understand how to address people with a history of substance use disorder. And we were at the beginning of that journey. So we didn't get it right at the beginning, but we learned from this patient, and we met him where he was at, and we strived to provide better care. We used hospitalization as a reachable moment to help this person who hadn't had a good healthcare experience for so many years prior. It was such an important moment for this patient to build trust with our hospital and the healthcare community, but it was also important to understand the role of the hospital in addressing opioid use disorder was really a fantastic outcome.